Welcome to our final session. We've covered epidemiological concepts and methods. Today we bring it all together with health services epidemiology, applying epidemiological thinking to healthcare quality, patient safety, and system performance. This is where epidemiology meets your daily work as healthcare managers. Tracking infection rates, monitoring readmissions, evaluating interventions, benchmarking performance, these are epidemiological activities. The skills you've developed in this course apply directly. Let's explore how epidemiology informs healthcare improvement. Health services epidemiology applies epidemiological methods to study healthcare delivery itself. Traditional epidemiology studies disease causation and prevention. Health services epidemiology studies how healthcare is delivered, who receives it, and whether it achieves intended outcomes. Key questions include: is care safe? Is it effective? Is it equitable? Is it efficient? These are epidemiological questions requiring population-level data and analytical methods. Health services epidemiology uses administrative data, hospital discharge records, billing claims, registries, as well as clinical data from electronic health records. This data is collected for other purposes but enables epidemiological analysis. Findings inform policy decisions, resource allocation, and quality improvement. They help identify variation in care, disparities in outcomes, and opportunities for improvement. For healthcare managers, health services epidemiology provides the evidence base for decision-making. Understanding its methods helps you generate and interpret this evidence. Quality measurement is applied epidemiology. Let me make this connection explicit. Every quality indicator is a rate or proportion. Surgical site infection rate. 30-day mortality rate. Hospital readmission rate. The epidemiological concepts you've learned apply directly. The numerator is the event of interest: infections, deaths, falls, medication errors. You must define this clearly, just as you define a case in outbreak investigation. The denominator is the population at risk: surgical patients, admitted patients, those receiving a medication. Getting the denominator right is essential for meaningful rates. Risk adjustment accounts for patient differences between units or facilities. A hospital treating sicker patients will have worse raw outcomes. Risk-adjusted rates enable fair comparison by controlling for patient characteristics. Benchmarking compares your rates to external standards, other units, other facilities, national averages. This is descriptive epidemiology applied to quality assessment. When you track quality indicators, you're doing epidemiology. The same principles of measurement, comparison, and interpretation apply. Patient safety epidemiology treats adverse events as health outcomes to be measured, analyzed, and prevented. The Institute of Medicine's 1999 report, "To Err is Human," brought epidemiological thinking to patient safety. Estimates that 44,000 to 98,000 Americans died annually from medical errors applied epidemiological methods to quantify harm. Incidence of healthcare-associated harm, surgical complications, medication errors, hospital-acquired infections, falls, is tracked using epidemiological surveillance methods. Root cause analysis for serious events applies outbreak investigation principles. What happened? Who was involved? What systems contributed? What changes would prevent recurrence? Surveillance for near misses and errors enables proactive safety improvement. Reporting systems collect data on events that could have caused harm, allowing intervention before harm occurs. Human factors analysis examines how system design contributes to error. Rather than blaming individuals, it identifies design changes that make errors less likely or less harmful. For healthcare managers, patient safety epidemiology provides frameworks for understanding and preventing harm. The methods are epidemiological, the application is operational. Administrative data collected for billing and management purposes enables health services epidemiology. CT's discharge abstract database captures every hospital admission in Canada, diagnoses, procedures, length of stay, outcomes. This enables population-level analysis of hospital care. Physician billing claims record every physician visit, diagnosis codes, procedures performed, dates. This tracks ambulatory care utilization. Prescription drug records from provincial drug programs show medications dispensed, what drugs, what quantities, for which patients. Laboratory and diagnostic imaging data capture test ordering and results. Data linkage connects these sources, creating comprehensive longitudinal records. A patient's hospitalizations, physician visits, prescriptions, and lab results can be linked to understand their care trajectory. Strengths of administrative data include large sample sizes, population coverage, and low cost. Limitations include coding errors, limited clinical detail, and absence of important variables like symptoms and functional status. For healthcare managers, understanding administrative data helps you use available information and recognize its limitations. Evaluating whether interventions work requires epidemiological thinking. Quality improvement is applied research. When you implement a new protocol and outcomes improve, did the protocol cause the improvement? This is a causal inference question. Plan, do, study, act cycles are iterative improvement. Plan the intervention, implement it, study the results, act on findings. Epidemiological measurement is central to the study phase. Interrupted time series analysis examines trends before and after an intervention. If the trend changes at the intervention point, that's evidence of effect. This method is stronger than simple before-after comparison. Before-after comparisons are common but vulnerable to confounding. Secular trends, seasonal variation, and regression to the mean can masquerade as intervention effects. Be cautious about attributing improvement to your intervention without considering alternative explanations. Implementation science methods study how to effectively introduce interventions into practice. What facilitates adoption? What are barriers? How do you sustain improvements? For healthcare managers, these methods help you evaluate your improvement initiatives rigorously rather than assuming that any improvement proves your intervention worked. Health equity analysis applies epidemiology to identifying and addressing disparities. Healthcare outcomes vary by socioeconomic status, geography, race/ethnicity, indigenous status, and other factors. Epidemiological methods quantify these disparities. Stratified analysis examines outcomes separately for different populations. Do surgical infection rates differ by patient income quintile? Do wait times differ by region? Stratification reveals disparities that aggregate data conceals. Social determinants of health, income, education, housing, employment, profoundly influence health outcomes. Healthcare delivery alone cannot eliminate disparities rooted in social conditions, but healthcare can avoid exacerbating them. Equity is increasingly recognized as a quality dimension alongside safety, effectiveness, and patient-centeredness. A healthcare system that achieves excellent average outcomes while failing vulnerable populations is not truly high quality. Canadian data reveals significant disparities. Indigenous peoples have lower life expectancy and higher rates of many conditions. Northern and rural populations have limited access. Income-related health gradients persist despite universal insurance. For healthcare managers, equity analysis helps identify which populations are underserved and guides targeted improvement efforts. CHE is the essential Canadian resource for health services epidemiology. CHE maintains national databases including hospital discharges, emergency department visits, ambulatory care, long-term care, and others. They also compile physician workforce data, health expenditure data, and more. Their health system performance reports analyze quality, access, and outcomes across jurisdictions. These reports enable benchmarking against provincial and national standards. Public reporting makes performance data available to citizens, providers, and managers. Your hospital comparison tool lets anyone see how hospitals perform on key indicators. CHE provides analytical tools and methodologies. Their case mix groupings, risk adjustment methods, and indicator definitions are standards for Canadian health services research. For healthcare managers, CHE is an essential resource. Know what data they hold, what reports they publish, and how to use their tools. Much of the evidence you need for decision-making comes from CHE. The parallel in the US is AHRQ and CMS data, in the UK, NHS Digital. Every healthcare system needs this infrastructure for health services epidemiology. As we conclude this course, let me summarize what we've covered and look ahead. Epidemiology is the population-focused study of health and disease, who gets sick, where, when, and why. It's the foundational science for public health and healthcare management. We covered measures of disease frequency and association, incidence, prevalence, relative risk, odds ratios, NNT. These are the vocabulary of epidemiological analysis. We examined study designs, descriptive studies, cohort studies, case control studies, randomized trials. Each has strengths and limitations for different questions. We explored threats to validity, bias, confounding, chance, and frameworks for causal inference. Critical appraisal requires understanding what can go wrong. We applied epidemiology to screening programs, surveillance systems, and outbreak investigation. These are epidemiology in action. Finally, we connected epidemiology to healthcare management through quality measurement, patient safety, and health services research. Epidemiology continues to evolve, new methods for causal inference, big data applications, implementation science. Your learning shouldn't stop here. Thank you for your engagement throughout this course. I hope you'll apply epidemiological thinking in your work and continue developing these skills. Questions? I'm always available to discuss how these concepts apply to challenges you face. Best of luck in your careers.